introducing Dr. Keely Cheslack-Postava. I'm sorry if I'm pronouncing your name wrong. She's an assistant professor of epidemiology and psychiatry at Columbia University. Dr. Postava has extensive experience and expertise in environmental epidemiology and biostatistical analysis, incorporating biomarkers and social determinants of health in epidemiology studies. Her research primarily focuses on the life course neuropsychiatric sequelae of prenatal and early life exposures, as well as on methods for addressing complex exposures in epidemiological research and research application of national survey data. Dr. Postava is currently an MPI for the intergenerational transmissional trauma, long-term well-being of children of World Trade Center responders with PTSD. Her other MPIs also on this study are, I'm sorry for the names again, Sikowitz, Rodriguez Moreno, and of course, Dr. Postava. Welcome, thank you.
Good morning, thank you. Okay, would you tell me now, can my screen be seen?
Yes, we can see the screen.
Okay, great, okay. Here we go. So I'm going to present this morning on COVID-19 and healthcare workers in New York. This is a little bit different actually from, if you heard in my introduction, from the topics that I have typically looked at, but as we know, came about due to the pandemic. And so I'm going to present some on some work that we've been doing in that area. Okay, so I'll just first give an outline of what I'm going to go through this morning. First, I'll talk about a little bit of background about the COVID pandemic first wave in New York City, and about the healthcare worker exposure there and kind of what healthcare workers were facing during this first wave in New York City. And then I'll talk a little bit about the survey, the CHPS, the Community Health Provider Survey, which was a survey which was implemented by a group of researchers in response to the pandemic, to seeing what was going on with the healthcare workers being exposed to these really difficult conditions, and kind of the realization that we needed to try to do some research to understand what was going on and to try to see what could be done to make things better. So I'll give some description of the background of that survey, of the methods and how that survey was conducted and the responses. And then I'll go into the specific question that I've addressed in my analysis and research with a group of researchers. Certainly all of this is done as a collaborative effort. And our specific question about examining the risk factors, and especially the occupational risk factors that were associated with adverse mental health outcomes in the New York State healthcare workers during this first wave. Then I will discuss the results of those analyses, and to also talk about some sensitivity analyses, and then go on to some conclusions. And so just a little bit about kind of my perspective and where I'm coming from. As mentioned in the introduction, I'm really always very involved with data analysis, with methods, kind of looking at the data. And so, this presentation, it's partly about the question that we were asking and the data that we collected and what we learned from that. It's also a little bit walking through how did we use that data? What were some of the different ways that we looked at it, kind of demonstrating those different ways to use the data to learn as much about this question as we could. And a caveat always is that this was, the data are the data, but our analysis and presentation of that data is always one way of doing things, and there's many different ways. And so, I'll welcome questions and possible, ideas about different ways to do that. Okay, so as you know, the COVID-19 pandemic kind of took over, really began taking over throughout the world in the spring of 2020. In the initial surge of COVID-19 cases, in really one of the epicenters in the United States for that initial surge was in New York City in the spring of 2020. And so what you see here is a graph showing the number of new COVID-19 cases that were in New York City from all the way over beginning March 8th, 2020. So the very early spring of 2020 through October 15th, 2021. So this is showing, if you consider this whole span of time, this is close to current day. So really showing how this has played out thus far in terms of New York City cases. One thing I'll mention just about these counts is that, what I've chose to show here is New York City. And you may notice a discrepancy, those of you who are familiar with the geography of New York State. The data that I'll be talking about really covers all of New York State healthcare providers. It's not just New York City. And again, like I said, the geography, those of you who know, New York State is actually a much larger geographic area than New York City. However, New York City is New York City and the surrounding area has the highest population concentration. And in the early pandemic was really the center of where cases were occurring. That changed later as as the pandemic dispersed, cases dispersed geographically. But during the time period, we're thinking about really most of the cases were occurring in this area. So I think that this is the most relevant. And here I show you in the red, this is the time window when the data collection for the survey I'll talk about occurred. So it was really from covering mostly May and June, just the very end of April of that year. So you see relative to the cases, it's kind of right after that first peak when the cases are going down, but this peak has just occurred. And now what I'm going to show you, though, however, is, so you see it in this first graph, we had the peak. You see that later on, we didn't know it at that time, but there were also, other peaks coming of some sort of similar magnitude. However, this graph where I'm showing the same time span, now this is the number of new COVID-19 deaths occurring during that time. And you notice this first peak, how enormous that is compared to anything else that occurs, has occurred to date. So really, here's that time window of the data collection again. So really seeing, there were the cases, but then here are the deaths and the magnitude of what is occurring in the area during this time. And you can see, again, this red rectangle during the data collection, it's occurring. The death rate also is coming down at that time, but really still in part of that peak. And it's really just an enormous magnitude compared to anything else, in this area. So with this, this massive burden of deaths that were occurring, of cases and of deaths, these conditions created an unprecedented strain on the hospital resources in the area. So here I'm just showing a few of the, these are press coverage showing some of the headlines. These are from the New York Times, the major paper, obviously well known outside of New York, but clearly a major paper of New York City. So here the first headline, this is March 25th, still in March, 13 deaths a day in one hospital. They're calling it an apocalyptic coronavirus surge. And then if you look to the next headline that's showing, that I have here in April 9th, they're saying hospitalizations almost flat, but deaths keep rising. So even, think of that time window when it was already being called apocalyptic, and several weeks later, still they're seeing deaths keep rising. So really just an unprecedented strain. The cases were, as you saw, rising exponentially, and at that point there was about a 32% case fatality rate for cases that were, if cases were coming into the hospital. So things were really, really difficult. Some of the, exposures, some of the conditions that healthcare workers were facing in hospitals at that time. So this is, this is a figure and some information. This isn't from our study. This is from another publication, which was a survey conducted at a single New York City medical center during this time period. And so this was just asking respondents, workers at one medical center, about different types of exposures and experiences to which they said, did they say they were facing distress due to these exposures? And these were factors such as redeployment, being sent to work in different areas, doing different procedures, different jobs, and that what people were currently or typically accustomed to, having to make triage decisions about prioritizing care for patients, for all of these patients in desperate need, just the working with COVID patients, the fear about getting sick, about transmitting COVID to their patients or to their family, dealing with patient deaths, and with many patient deaths, working while symptomatic, having changes in the clinical hours, and lack of personal protective equipment. That was also a major, at that time, it was places were really struggling to get the PPE that people needed to be safe. Okay, so this study, this was that was one institution, and they didn't, this was just a what are people facing? It didn't look for specifically which factors were were most associated with mental health outcomes and with distress. Okay, so during this time, there was also evidence that, clearly that all of this was taking a toll on the mental well-being of our healthcare professionals. This was brought to the forefront very sadly and very shockingly in April 2020, when there was a death due to suicide of a well-known New York City emergency department physician in the area. So that really was one thing that that focused attention on this issue. Here I cite another paper that was conducted during the same month of April 2020, a study of internal medicine residents in one New York City hospital, was finding that almost a quarter of them had contemplated suicide or self-harm since the beginning of the pandemic. So very high rates. And then more broadly, just thinking about throughout worldwide, there's data from a meta-analysis of 65 different studies of healthcare workers in this paper was in 21 countries, and showed that depression and anxiety were widespread in healthcare workers during this time. And that paper did some pooling of the estimates and came out with right around 21-22% estimating that healthcare workers were suffering from depression, anxiety, and PTSD, each separately during that time. Now, certainly these estimates are these estimates should be interpreted cautiously. They're coming from all kinds of they're meta-analysis, so they're coming from all kinds of studies, different places, which would be different types of workers, different times during the pandemic, but really just an indicator of the toll of this pandemic on healthcare professionals. Okay, and so for us thinking about New York State and our New York State health providers, I'm describing the conditions I have been for the past few slides for the New York City area during this pandemic first wave, the area that was that was really impacted by the high case count, by the high death count. But you have to remember during this time, so what was happening, shutdowns were being implemented to try to stop this thing. And there were many areas that, had not seen the cases yet, and yet everything was shutting down. Everyone's staying home, social distancing. And so, it's also possible that there's collateral impact of those shutdown measures. It's what we need to do to stop the transmission of cases, but other things happen when, when everyone stays home. And so here's a headline saying, COVID-19's crushing effect on medical practices, some of which might not survive. And so thinking about healthcare providers, statewide, all healthcare providers, we thought we hypothesized, we don't know, there may be some who could be negatively impacted due to, as opposed to the exposure to the cases and the difficult working conditions, instead the lack of working conditions, seeing practices shut down, seeing loss of income, loss of livelihood, loss of contact with their typical, one's typical role. And as people, as other healthcare besides COVID was severely severely cut back for that time. Okay. So into this kind of with all of these conditions going on and seeing what was happening in response to this, a collaborative effort of several investigators, different institutions in New York City came together and launched the COVID-19 healthcare personnel study, the acronym CHPS, in response to seeing these events and thinking we have to do something to collect information, to learn what we can to make things better. What can we do? So this was a longitudinal study, or it was to be, it's planned and is a longitudinal study of New York State healthcare workers. So like I said, throughout the state, it aims to understand and mitigate the adverse impact of the COVID-19 pandemic on the healthcare workforce. And it was launched as a collaborative effort between faculty investigators at several New York City-based institutions. Those were Columbia University, New York University, the City University of New York, and the New York State Psychiatric Institute. It was a rapid response and voluntary effort, and so that means it was not funded. It was put together. It was put together rapidly, and so there's always, in hindsight, some things maybe you say, we think could have been done differently, or I should have done it this way or that way, but it was done quickly, so we did what we could. Okay, and so the results that I'll be presenting are from the first wave. I mentioned it was longitudinal, and there have been 2 waves conducted. This is going to be the information from that first wave, from that I showed you on the first few slides, the time period with those red rectangles highlighted. It was an online self-administered survey. It was relatively short, designed to be completed in 10 minutes. These are very busy people in stressed positions, so you don't want a long survey. The sampling frame included all licensed New York State healthcare workers as of April 2020. So that was over 220,000 licensed healthcare workers. The results I'll be talking about pertain to 139,000, to a target population of 139,000 physicians, nurse practitioners, and physician assistants. So the healthcare workers licensed with those in those roles in New York State in April 2020. They each received an email invitation from the New York State Health Commissioner. And like I had said, the data collection went from April 28th to June 30th of 2020. Although, as I'll mention, the vast majority of the responses actually came in within about 3 days. So the very beginning of that time window, just the end of April to beginning of May, first few days, most people who were going to responded within a few days, but they left the data collection window available for those who would respond but were slower to do so. So I'll just say this the survey has produced and will produce very multiple different papers, different investigations, but the group that I was working with, the group of investigators in partly from the steering committee for this survey, but also our researchers in Christina Hoven's GPEG research group looking at mental health, we worked together to investigate what occupational factors were associated with negative mental health outcomes in healthcare workers in New York during this first COVID pandemic wave. We thought that occupational circumstances are a potentially modifiable means through which to address mental health. And so that would be something worth studying. Looking at the literature, we saw that previous studies during different epidemics or pandemics found that increased psychological distress in different forms among healthcare workers had been associated with factors like direct contact and treating infected patients, being quarantined due to potential infection, having colleagues who were infected or died, having long hours, and having lack of training, PPE, or support. So, those were some of the things that we realized could be potential factors here. So, a bit of information about the response to the survey that I described. So the email went out to a little over 139,000 physicians, nurse practitioners, and physician assistants. 38,000 or 27% of those emails actually got opened. And then just over 2,000 completed the survey. So that, that 2,000, it was 5 to 6% of those who opened the email completed the survey. 1.5% of the total people to whom the email was sent completed the survey. Those numbers look very, very low, but this is typical from, what you get doing this kind of, doing this method of data collection. It's sending out vast numbers of emails to people who are very busy and, may or may not be looking at these things, may or may not be interested, may or may not have time. It's, so this is not a atypical response rate. So what we did though, was to create survey weights, and those are used to make the results so that, those results that are only come from 1.5% of our target population, but we know for those respondents, their age, their gender, and their geographic, the region they came from geographically. And we also know that information about the total target population of those who were invited. And so, one thing we can do to make the information that we did get a little bit more representative of those who we targeted is to create these survey weights. And those just go back and we applied those in all of the data analysis to make the population a little bit more representative, at least in terms of those factors, age, gender, and the geography. Of course, we can't address all kinds of other factors that differ between people, but this is, some improvement. So the distribution of the sample by profession was about 3/4 or represented about 3/4 physicians, 15% nurse practitioners, and 11% physician assistants. Their characteristics overall, females make up a little less than half. The 40 to 59 age group is over half, represents over half, with the under 40s and 60 or over each around 20%. Almost 70% of the respondents here said that the New York City metropolitan area was their usual workplace. So again, this focus on the New York City area where the pandemic was really hitting hard at this time point. There was a distribution of different specialties, primary care being most heavily represented. About 45% reported that they had children under 18 at the time, and just over 30% answered the survey anonymously. And that was important to think about because of, as I mentioned, it was a longitudinal study, and so those who answered anonymously could not be recontacted to participate in the additional waves. So, so this is of concern for the future waves to see kind of based on this first wave, were the people who answered anonymously different or similar to those who gave their information and said, hey, I'll participate in another wave. So these are the overall characteristics. And then thinking about when we broke down the groups separately by their professions, the nurse practitioners and physician assistants were more likely to be female relative to physicians, and the physician assistants were less likely to be in the older age group of 60 plus. So here are, this slide shows the prevalence of some different pandemic related occupational experiences, some of these different work conditions that that people were exposed to. Now you have to recall this is relevant to this population at this certain time point. So it's certainly not, if we go forward, indicative to what someone might be, what has someone been experienced over, 12 months, 18 months of the pandemic. But this is a snapshot right at the beginning. You see things like a little more than 20% were had stayed in their same work location but changed the function that they were asked to do. About 15% redeployed, so that's actually a different location. That was in the gray. In the blue, we have some different variables about their work hours over the past 2 weeks. So we're asking people, has that changed? And actually 40% said it was less than usual and 40% the same as usual, but then 20% reported that they were working more than usual. In the light blue, we see kind of the hours. It's almost kind of a normal distribution. You have from most people right in that middle 41 to 80 hours, but some had been working none, some had been working, over 100 hours over those past 2 weeks. And then in the orange tones, we see the exposure of things like about just over 50% had been working with COVID patients, 20% had family or friends who had died, 30% had COVID symptoms, almost 60% had patients who had died, 10% were involved in triage decisions, and then facing shortages, over 50%, 55% of PPE, and then other shortages were faced by over 35% of participants. Okay, so our question, how do these things relate to mental health? We assessed mental health, at least for this analysis, using 4 dichotomous outcomes. So we took this information that we had and we dichotomized these 4 different measures of mental health. So there was depression was assessed by 2 items, and those were each scored on a scale. A positive score was considered a sum of 3 or more. Anxiety was based on a similar 2-item scale. So, you realize these are relatively simple assessments. They're not clinical diagnoses, but they're indicators of whether a person seems to be or may have depression, may have anxiety. And then for stress and for anger, we had items that were asked how frequently you experience this emotion because of COVID-19. Those were asked on a scale of 1 to 10. 10 being extremely often. And so we just used a dichotomous indicator where a positive score was greater than or equal to 8. So the prevalence of each of these individual outcomes, you can see the bar graphs over here by profession. Overall, the prevalence for depression was 13%, for anxiety was 26.5%, for anger was 8%, and for stress was 29%. And you can see the kind of gradient in general there. It was the physicians who had the lowest risk and the physician assistants with the highest, but they're similar patterns for each of those outcomes. Okay, and so in terms of our strategy for looking at the relationship of these factors to mental health, we have these 4 dichotomous indicators for different factors that can indicate someone's, if someone might have poor mental health, might be having mental health issues. However, our interest here is really getting at those factors that are risk factors for negative mental health overall. We weren't so interested here in saying, which, does a certain factor, lack of PPE, is that more related to anxiety or is it more related to depression? We're saying, well, we're not interested in saying, is it anxiety or is it depression? What we really care about is it has a negative impact on someone's mental health and identifying those things. And so in order to use those 4 indicators, but to ask the question kind of comprehensively about the impact on mental health overall, we treated the mental health problems as a multivariate outcome. So meaning we had 4 indicators, which were set up in the data as 4 observations per subject. So we're saying we kind of looking at listing out those 4 outcomes per person, but we're looking at a dichotomous outcome overall of mental health problems. We used logistic regression, which is appropriate for dichotomous outcomes. And for those of you who may be interested, we use generalized estimating equations to account for the correlation between those outcomes, because we're saying we have 4 different outcomes per subject. Someone who has one negative mental health outcome is more likely to have other problems. So there's correlation, and this is a method to account for that correlation. And some of the functions, if you're familiar with statistical software, could be done in SAS Proc GenMod or in XTGEE functions in Stata. Let me see, we set the data up like this. So this is just an example for one subject. We have 4 observations. So this is, you can see an ID. This is just a sample subject. If we called this a subject number 12, this X is an indicator variable. So a 0, 1 for the exposure of interest. So say this was a PPE shortage. So this is X equals to 1. This person experienced PPE shortage, and that variable is 1 for every observation because that's because they experienced that. So we always say that's 1. We have these indicator variables. These are basically 3 variables that you use to specify what outcome you're looking at, whether it's depression, anxiety, stress, or anger. So we can vary those in order to incorporate the different mental health outcomes we're looking at. And then this Y is our outcome variable. That is a 0, 1 variable that indicates whether the subject is positive for the outcome that's listed in each row. So here, this example subject was positive for depression. They have a 1 in that first row. You see that first row indicated depression, but they weren't positive for these other outcomes. And so, we can use that, those 4 mental health outcomes for this subject to learn about their mental health overall and their exposures. This is just a slide showing kind of the equation when we run the logistic regression analysis. What is the model that is being run here? And I'll just point out the highlighted line. This is, sort of in equation form, the same variables I just showed you, but we have this, we'll get this estimate for the beta 1 for our X1. Our X1, you remember, was the exposure we were interested in. Here we were interested in PPE shortage. So if we said this X1 was a PPE shortage, then using our exponentiating our coefficient, we get an odds ratio. And the point here is we can interpret that odds ratio as an odds ratio for the overall effect on negative mental health associated with our exposure of interest. So here it was PPE shortage. So we're getting that estimate for overall negative mental health, which we're basing on these 4 different indicators. And then in this model, of course, we can adjust for additional covariates, and we can also do a test of whether that beta 1 here, that estimate, varies by the mental health outcome that we're looking at. So, kind of our presumption that it's really, it's not that it matters whether it's depression or anxiety or anger, it's overall going to have these exposures will have an overall effect on mental health altogether. We can, test that assumption and make sure that makes sense based on our data. And, I'll just go ahead and say right here, because as I go through the results, we did that and it didn't, that assumption turned out to be good for our data. So, so that worked. Here we have the associations of, and so these odds ratios that I show are interpreted like that. They're odds ratios for the overall negative mental health based on these 4 indicators. So here we found, looking in this odds ratio column, that having a higher prevalence of negative mental health outcomes was significantly higher among females, among those who were younger providers, those who were not the physicians, so who were nurse practitioners or physician assistants, those whose usual work location was the Metro NYC area, critical care specialists as a specialty. And then there was no difference depending on whether participants answered anonymously. And so we were, glad to see that factor didn't seem to make a difference, since that was kind of a data collection related factor instead of a real personal characteristic. So looking at the work-related conditions that were associated with their increased odds of negative mental health, we saw that here, and so these, let me first say, these are from a model that adjusted for all of those personal characteristics we were just looking at. So, someone maybe older providers versus younger providers tend to have certain types of exposures. We're adjusting for that. We're accounting for that in the analysis. So after accounting for those factors, we see that the redeployment did not really have an association. Working more hours in the past 2 weeks, however, increased one's risk. So did having had family or friends who died, having COVID-19 symptoms, and being involved in triage decisions, and then the shortages of PPE and other shortages. These are what I'm looking at here. What indicates a significant association is this this blue dot, this estimate for the odds ratio being above that red dotted line. And if it's if the estimate is above and it's this little black line you're looking at, that's the confidence interval. That being above the red dotted line indicates that you have an estimate above 1 there. Okay, so when we put then we put this all together, and when we accounted for all of these different exposures all together, what did we see? This is the ranking here, top to bottom, of the most strongly associated exposures with adverse mental health outcomes. So PPE shortages at the top, and followed by COVID-19 symptoms, having family or friends who died, having an increase in work hours over the past 2 weeks, and other shortages. And so the triage decisions that I had shown on the other page was the only one that became non-significant after we accounted for all the exposures together. Now here, we had only looked at the relative work hours in that model, whether they worked more or less or the same. We couldn't look at the actual number of hours and the relative number of hours at the same time because there's collinearity, meaning that you're kind of looking at the same thing. But when we looked instead at the actual number of hours that worked, we see this kind of U-shaped relationship. As expected, the highest number of work hours was the only one significantly associated with negative mental health. But we do, if you look at that none, there's, it's kind of above the line for 1. The confidence interval crosses 1, meaning it's not statistically significant. But there's some indication that there could be something going on there. It was a relatively small group in the data, and we couldn't test it extensively. But, some hypotheses are, for one thing, these could be people who actually had been sick and so weren't working, or these could be people who were affected by some of what I mentioned earlier, people who were not able to work, even perhaps if they had wanted to, because of some of the closures, but we can't be sure. These are just hypotheses about that group. So in looking at the symptoms, we saw an association of mental health outcomes in those who had COVID symptoms. We broke it down to look at the relationship of having symptoms to working with those symptoms. And what we saw was this dose response relationship, where it was really the people who worked. So there was an elevated risk in those who worked while they were sick, and really above to the highest risk in those who reported that they were working in direct patient care while they were sick with COVID symptoms. What proportion of people did that affect? It was about 30% who had symptoms, and the light blue in the pie, and then over here in the smaller pie, this yellow, about 11% of the population who were working while sick. We looked also at what other shortages are associated with people. The other shortages were associated with negative mental health. So we looked at some of those specific factors, and we saw that it was the personnel, the ventilators, and the beds, really not the test kits, but these other factors, which might be associated to the ability to provide care, and really speaking to some of those drastic experiences people were facing, where there were, even shortages of beds for patients. So we did a few sensitivity analyses. I'll just touch on these briefly. I think we, as we're running short on time, I had mentioned that most of the responses came in kind of right away the first few days. So we did one analysis where we just restricted to those responses because we thought, hey, maybe those people are much different from the people who respond after quite a delay. That was, it was 84% of the participants responded within, who were going, if they were going to participate, did so in those first few days. And then the multiple imputations, I won't go into the details, but this is a method for dealing with the missing data. We had about 10% of observations that we weren't able to use in our full analysis because they were missing information on some variables. Multiple imputations is a way of using the data you do have to make a kind of reasonable, to fill the data in with reasonable representations of what it would be in those observations to make more full use of that data. And both of these analyses gave us findings that were really consistent with the main findings. So that gives us confidence that, those issues aren't impacting our findings. Okay, so in summary, after adjusting for the personal characteristics and other occupational factors, there were some different exposures related to adverse mental health outcomes in the healthcare workers. Some of those were potentially modifiable, maybe through institutional measures, and those are things like their increased recent work duration, PPE, and other shortages of resources, and working with patients while sick. And some of those are less modifiable, like the loss of family and friends and experiencing COVID-19 symptoms, although those things may be possible to ameliorate through societal level measures that just, addressing the pandemic in general. And like I said, we didn't have any strong evidence that these risk factors varied a lot by the specific mental health outcome. So, is one thing associated with anxiety as the other related to depression. These were, overall adversely impacting mental health. And so the themes that we kind of see here are personal exposure, factors that may represent a breakdown of institutional protection. So when you're not, you're not getting the PPE and other equipment needed at work, having to work longer hours, and people working while sick, which can be called in the literature presenteeism. Although, to be clear, we don't know whether it was their employer that asked them to keep working or just the, people feel, want to help. It's a situation where, personnel was people weren't, people needed everyone kind of all hands on deck. And but the protections weren't there to kind of keep that from having to happen. So this is kind of a hypothesis or interpreting the data, but this may be this may lead to what's termed moral injury, a feeling of inability to adequately care for those who providers are responsible, and can involve a feeling of being betrayed by a trusted authority. So, when not having the equipment that was supposed to be there. So, and these factors are potentially modifiable by changes in, for a good part, and changes in institutional or governmental policy, maybe in workplace culture, and then when not avoidable, identifying them is important in order to make the impacts on individuals mitigated, perhaps through debriefing methods, through treatment approaches, being aware that these factors, these exposures are likely to have a negative impact. Okay, so in conclusion, a number of the circumstances identified as increasing risk for healthcare workers' mental health during the pandemic are modifiable by changes in institutional and governmental policy. these findings may identify specific targets for modifications in healthcare worker occupational settings. And the positive message here is that reductions in these risks may potentially be achieved. So I'd like to acknowledge many people here. We have the PIs and the steering committee and the co-investigators for the community health providers study overall. And then certainly some of these individuals are also co-authors, contributors to this analysis and paper, and we also have some GPEG co-authors and participators in the working group on this analysis, and Columbia co-author. Thank you all for your attention. Here's my email.
Thank you so much, Dr. Postava. We're going to open the floor for questions now. If anyone in my in-person audience, you have a question, you can raise your hand and I'll bring the mic over to you. And for my audience on the Zoom, you can either unmute yourself and ask a question, or you can type it in the chat and we'll get it answered.
Thank you very much for a very informative presentation. I was particularly interested because we're currently we have PAHO doing a course on the GAD and the tools for cognitive behavior therapy. And I'm doing a little study myself among young offenders to find out their level of anxiety and depression as a result of this COVID-19 pandemic. So my question is, I think from what I gathered, there was no direct impact on COVID-19 on the anxiety depression levels, or the prevalence of anxiety and depression among the healthcare workers. Am I correct? Assuming this from the presentation that you made.
Okay, I'm sorry, I'm not quite sure if I got all of that with the microphone, but so you were asking, we were looking at the prevalence as opposed to the effect on levels of anxiety and depression, is that?
Right.
Okay, yes, and so we didn't, the analysis that I presented was looking at prevalence. Yes, it wasn't looking at the level. As I mentioned, and sorry, I realized I had to go a little quickly. There are measures for anxiety and depression were really just each based on 2 items. Certainly we could look a little more at the levels. We don't have a very comprehensive measure about levels, but here we did just treat them dichotomously. As I said, in fact, our findings that I presented really relate to the overall negative mental health indicated by those variables, as well as the anger and stress. And we did treat them dichotomously. But again, as I also said, I think that looking at very specific variation in the levels is also would also be useful, and there's certainly many more things we can do. Thank you.
Thank you so much, Dr. Postava. We are running out of time right now, so we won't be able to take any more questions. But as you all know, that Dr. Postava gave her email. If there are any questions, you can definitely reach out to her. Thank you so much, Dr. Postava, for this amazing presentation and taking some time from your busy schedule to be here with us today. It was really wonderful having you.
Thank you all.